Welcome to this podcast on an introduction to normal labour. I'm Susan Bewley, a consultant obstetrician at Guy's and St Thomas's in London and editor of the OUP book Training in Obstetrics and Gynaecology. In this podcast, we'll look at normal labour, starting with the basics, explaining the stages of labour and some of the mechanical factors involved, and then the management of normal labour. The definition of labour is the presence of uterine contractions that lead to dilatation and effacement of the cervix. During pregnancy, the uterus is quiescent under the influence of progesterone largely, and the cervix is firm and closed. At the end of pregnancy, the uterus becomes more active, first of all with Braxton Hicks contractions, and then the cervix open to allow the baby to deliver. Labour is a normal process, and the key to intrapartum care is to support, supplement, and on occasion replace the normal process. The different stages of labour. Labour is divided into 3 stages. The first stage, from the initiation of labour to full dilatation of the cervix. The second stage is timed from the full dilatation of the cervix to delivery of the baby. And the third stage is that between the delivery of the baby and the delivery of the placenta. The first stage, from initiation to full dilatation of effacement of the cervix. Initiation is sometimes difficult to time. Women may have contractions that start and stop, often coming in an evening and going quiet, and then one day the contractions will continue. They will become closer and closer, they become more painful, and eventually they are causing the process of the cervix to go from ripening to opening. The first stage is sometimes divided into the accelerative phase and the transition phase. So before labour, the cervix is closed. During ripening, or the latent phase, the cervix becomes soft and starts to open. The accelerative phase is where the cervix increasingly opens from 2 to 3 centimetres or so to about 8 or 9, and then just before full dilatation there is the transition phase. Sometimes this is also called decelerative because the opening seems to slow down slightly. It's also the most painful and the most frightening for women when they feel out of control, but it is followed shortly by the pushing phase, which is a positive one leading to delivery. Effacement is the process by which the cervix shortens from usually about 3 centimetres or so to being thin and almost paper thin and then opening. As the cervix effaces, the jelly-like material that was in the cervical canal can come out, and women will often describe what we call a show. This may be a mucousy or brownie coloured discharge from the vagina, often with the consistency of egg white. It must be distinguished from active bleeding, which is where blood will be seen, which will be red. Dilatation of the cervix is where the cervix opens from 0 centimetres to 2 centimetres. And at the beginning this may occur along with effacement, but sometimes effacement happens first and then dilatation. It depends on the muscle, the smooth muscle of the uterus, progressively contracting and relaxing and contracting and shortening. And this process is different in the upper and lower segments of the uterus, eventually creating the power to pull the cervix up and open and out of the way, and then propel the baby through the birth canal. Full dilatation is when the cervix has been fully pulled up into the lower segment and cannot be felt vaginally, and by convention this is called 10 centimetres. The rate of dilatation varies with parity. A first labour is commonly 12 to 18 hours long, whereas a second and subsequent labour is usually shorter so long as there is no obstruction. The second stage is where the cervix, which has been fully dilated, is used to time it until the delivery of the baby. It is divided into two parts. The first part is the passive descent of the head through the pelvis and onto the pelvic floor, often with some rotation. And the active part is where the head is on the pelvic floor, causing the mother to feel the urge to push, and this often becomes uncontrollable and she pushes. There are two types of pushing, undirected and directed, and increasingly it is thought better that the mother should push as she feels like, rather than holding her breath and being shouted at by the midwife and her attendants. It is important to understand the anatomy of the pelvis and the movements of the head during delivery, as the normal fetus, which presents by the vertex, will have a flexed head, go in sideways to the pelvis and rotate so that it is then facing nose down to the floor or towards the anus, and then as it comes through the birth canal and out through the vulva, the head will extend, and so what is seen from outside is the forehead followed by the face. In malpositions and malpresentations, this does not occur. The key anatomy are the planes of the inlet, where, as you can see on this diagram, the inlet is 11 centimetres and the outlet 13 centimetres. The inlet is wider in a transverse direction, which is why the oval-shaped presentation of the vertex goes in a transverse way, or what we call occipito-transverse. So the back of the head and the front of the head, with the occiput and the sinciput, or the posterior fontanelle and the anterior fontanelle, will be seen on left to right or right to left. And then the baby rotates, because the outlet, which is also an oval shape, is an oval shape that is at 90 degrees to the inlet, and this can be seen in this diagram with the outlet at 13 centimetres in green. The transverse plane here, the inlet is wider and the outlet is narrower, and this explains why the baby has to make a rotational movement, firstly of the head and secondly of the shoulders, to be delivered. The ischial spines are used as landmarks by the accoucheur, the midwife or the obstetrician, to assess descent of the head. Descent of the head is also assessed abdominally. If you imagine a setting sun going down over her horizon, first of all you feel 5/5 of the head abdominally, and then progressively 4, 3, 2, 1 and 0, and that is the head entering the pelvis abdominally. Engagement is when the widest part of the head has passed the inlet of the pelvic brim, i.e. at 2.5 of the 5/5. So what you feel left in the abdomen is 3/5, that head is not engaged, and a little bit more goes in, 2/5, that head is engaged. However, in labour, we also assess the baby coming out through the vagina through what we feel with our fingers as descent of the head. And this is done through the concept of the station. The two ischial spines are station 0. While the head is in the abdomen, it is far away from the vagina, so it is minus. And when the leading part of the head is 2 centimetres above the spines, we call that -2. As the head descends into the pelvis, we feel the leading point at the level of the ischial spines, and we say that is station 0. And as the head descends further, just before it's ready to deliver, it might be 2 centimetres below the spines and be +2. One of the things that can confuse students and midwives and obstetricians is that the head changes shape. It isn't a fixed round object descending through the pelvis, but one that moulds and changes from a football shape to a rugby ball shape. And therefore, you can have a head that is moulding, but still not going into the pelvis. So if there is 2 or more fifths of the head palpable in the abdomen, even if something is advancing down below, that might just be the moulding of the head and a point on the head coming down, or a bit of caput, a bit of swelling on the front of the head. So it's important to assess descent both abdominally and vaginally. What are the definitions we use to describe the baby? The presentation is that part of the fetal body that is foremost within or close to the birth canal. We assess this from the abdomen, and if the head is presenting, we call that cephalic. If the bottom is presenting, the breech, and if a baby is lying transversely or obliquely, it might be the cord or the shoulder that is presenting. The lie of the baby is the relation of the fetal spine to the uterus, and so when that is longitudinal, the baby can be head or bottom first, and a longitudinal lie is normal. The presentation that is normal is cephalic. The presenting part is the lowest part of the fetus that is palpable on vaginal examination. If the baby is cephalic, depending on whether the head is very flexed with the chin on the chest or very extended with the back of the head on the shoulders, it can be a vertex or a brow, or the most extreme, a face. A vertex can deliver vaginally, as can a face if it is mento-anterior, that is, the chin is at the front, but a brow, unless it is very premature, or a face that is mento-posterior, cannot get round the curves of the pelvis, and they will become obstructed. To be able to describe which way round the head is in relation to the pelvis, we have some further definitions. The position of the baby is how we explain which part of the head is in relation to the circularity of the pelvis. We define a part as the denominator, and then we look at that rotation of that part in relation to the pelvis. So in a vertex, the occiput, which is the posterior fontanelle, may be at the front, that would be OA, at the side, which would be OT, or at the back, which would be OP. The position of a breech is determined by the denominator, which is the sacrum, and a baby can be sitting with its bottom facing the side or the back or the front, and that will be sacro, transverse, posterior or anterior. The attitude of the fetus is the posture assumed by the fetus, and that is related to whether it is flexed or extended. The whole baby can be flexed or extended in terms of its spine, but also the neck, the hips and different parts may be flexed or extended. This is not usually very relevant to labour itself. In the second stage, the occipito-transverse position usually engages going through the oval of the inlet. It descends, the head flexes some more, and the head, whichever part hits the pelvic floor first, thanks to Ferguson's reflex, will rotate to occipito-anterior. So the baby, instead of facing sideways, will rotate to face nose down. In the active part, there is further descent, usually with the maternal pushing as well as the powers of the uterus, and then as the head comes through the vulva, it extends to deliver. The third stage. This is the delivery of the fetus to delivery of the placenta, cord and membranes. This usually occurs in under half an hour, but can take longer. After an hour, the placenta is determined as retained, and that is an obstetric emergency associated with hemorrhage, and it's important to transfer a woman to a place of safety or to a theatre to consider removal of the placenta. The normal blood loss at a normal vaginal delivery is 100 to 300 mils or so. The definition of a postpartum hemorrhage is a loss of more than 500 mils. Many women can tolerate 500 mils depending on what their haemoglobin is, but obviously a larger blood loss can compromise the mother. The third stage relies again on the smooth muscle of the uterus contracting and also retracting, the fibres becoming shorter and shorter, and these will compress the blood vessels to stop bleeding. The most dangerous time for the mother is the third stage, and the most common cause of postpartum hemorrhage is uterine atony, that is, the uterus relaxing and not contracting. The other major cause is retained products, maybe a cotyledon of the placenta or a small bit of membranes. So now we will look at the management of normal labour. The most important thing is not to be frightened of emergencies or of the noises women make during normal labour, and keep visiting the labour ward to look and see who's in labour, to anticipate the progress that's expected, to support the woman and her companions, whether that be the midwife, her partner or her friends, and to play a positive interest without any signs of anxiety or panic. The most important thing is to diagnose labour. Sometimes it is not clear at the beginning whether contractions or tightenings are Braxton Hicks, these are usually painful, or the latent phase of cervical ripening. It has been shown in numerous studies that the most important thing is that a woman gets one-to-one support, preferably from an experienced and trained midwife, but also from her companions. Often women like her mother or sisters who've had children before are very helpful, and many partners can be very supportive also. A doula is a non-professional woman who may also be someone who can provide support, although this is seen more in developing countries but also a little in the UK. The woman needs continual monitoring and evaluation during labour, firstly to see that she is coping with the periods of rest between contractions where she can regain her strength and be prepared for the next contraction, but also her vital signs, particularly blood pressure and that she is passing urine. Her pain relief may be through her own coping mechanisms or a variety of pharmacological and physical treatments that are available. The level of monitoring will depend on the risk. Obviously, a woman who's having induction for preeclampsia with a small baby will need more monitoring, particularly of her fetus, than a woman who's had 2 children already and is delivering in a homely circumstance or even at home. It's important to encourage regular bladder emptying so that the bladder does not obstruct delivery, and also so that the urine can be tested. It is no longer fashionable nor needed to perform perineal shaving or enemas, and analgesia should be provided as it is requested or required, remembering that the need for analgesia is lessened by knowledge, prior support and belief and confidence in her body and her abilities, and by the presence of supportive companions. Maternal observations are made every 1 to 2 hours, and vaginal examination is usually performed 4-hourly, although more commonly at or around full dilatation and in the second stage. The important things on vaginal examination are the dilatation of the cervix, the station of the head, working out the position and whether the baby is rotating to a good position to push and deliver, and also very importantly testing for fetal condition through the amniotic fluid, which should be clear. No amniotic fluid is of concern because that may mean the baby has oligohydramnios, or that the head is blocking it, and therefore one would not know if there was meconium. The fetal heart should be listened to every 15 minutes in active labour. After full dilatation, women should be encouraged to push once they feel the urge is uncontrollable or the head can be seen at the vulva. Some women with occipito-posterior positions have an urge to push too early, and they may try and push when they are only 8 centimetres or so, and this can cause cervical edema and even obstruction. As the head is crowning, that is, it's extending and the largest diameter is coming through the vulva, it's a good idea to ask women to stop pushing actively so that the head does not come through the vagina precipitously and cause tearing of the perineum, and she should be encouraged to pant or just give small pushes. After the head is delivered, it will restitute back to being OT and in line with the shoulders, and the shoulders will be delivered either anterior or posterior first, but one at a time. The usual routine in the UK is to advise active management of the third stage, as this has been shown in many randomised trials to reduce the risk of blood loss. Although syntmetrin and less so syntocinon can cause a bit of vomiting and elevated blood pressure. The 3 parts of active management are the administration of an oxytocic, usually IM but occasionally IV, controlled traction, which is where the cord is pulled whilst the other hand is placed just above the symphysis pubis to ensure that the uterus is held back and cannot invert. A third part has been considered to be necessary as early cord clamping, but increasingly we have realised that this may interfere with placental transfusion, the blood from the placenta entering the fetal body to help open up the pulmonary circulation, and so cord clamping is no longer considered a necessary part of active management. So in summary, in this podcast we've talked about normal labour, the different stages, the mechanism of delivery of the baby, the management and monitoring that's required, and the support that helps at that most exciting and important life transition, the birth of a new baby and the birth of a new mother at the same time.